Tetralogy of Fallot is a congenital heart disease which has 4 anatomical defects, which are: ventricular septal defect, overriding of aorta, pulmonary stenosis, right ventricular hypertrophy. It causes deoxygenated blood flow out of the heart and into the systematic circulation. It is most common cyanotic heart disease and most common cause of blue baby syndrome. Ventricular septal defect is an opening in the intraventricular septum that permits communication between two ventricles. Overriding of aorta is condition in which the aortic valve is enlarged and appears to rise from both the left and right ventricles instead of the left ventricle. Pulmonary stenosis is the narrowing of the pulmonary valve and outflow tract that creates an obstruction of blood flow from the right ventricle to the pulmonary artery. Right ventricular hypertrophy is thickening of the muscular walls of the right ventricle in response to pressure overload in the right ventricle. Etiology of Tetralogy of Fallot mostly is genetic and chromosomal disorders like trisomy 21, Turner's syndrome, mutation in genes such as 20p12, 8q23, 5q34, microdeletion of q11 on chromosome 22. It can also be due to fetal and maternal teratogenic infections like rubella. Teratogenic drugs like thalidomide, hydantoin, retinoic acid, carbamazepine, etc. can also lead to Tetralogy of Fallot. Alcohol and poor nutritional intake by the mother during pregnancy, radiation exposure during first trimester, also increases chances of TOF. Now, let's discuss clinical manifestations. The 3 characteristic symptoms are cyanosis, hypercyanotic or tetrad spells, and squatting. The degree of cyanosis and symptoms are variable. Any event that lowers systemic vascular resistance increases the right to left shunt and leads to symptoms associated with hypoxemia. Exercise, heavy meals and hot weather lowers the systemic vascular resistance, increase right to left shunt and leads to increased cyanosis. Hypercyanotic or tetrad spells are uncommon nowadays because of correction and palliation with a shunt. Squatting is diagnostic of Tetralogy of Fallot. During exercise or exertion, the unoperated child squats to rest. Squatting increases systemic vascular resistance, thereby reducing right to left shunt. For diagnosis, blood studies shows polycythemia and high hematocrit level due to cyanosis and decreased blood flow to the lungs caused by pulmonary stenosis. The electrocardiogram reveals right axis deviation and right ventricular hypertrophy associated with tall R wave in lead V1 and shorter in lead V2. In patients with pulmonary stenosis and restrictive VSD, right precordial leads show deeply inverted T waves. Chest X-ray may classically show a boot-shaped heart. The cardiac apex is turned upward, and the pulmonary artery segment is concave because the pulmonary artery is small, also due to right ventricular hypertrophy and right atrial enlargement. Echocardiography can also be done. Cross-sectional echocardiography in views parallel to the long axis of the left ventricular outflow tract shows a large aortic root overriding a large ventricular septal defect. The infundibulum, pulmonary valve annulus and pulmonary arteries appear small. Color Doppler shows accelerated, turbulent flow through the right ventricular outflow tract. In cardiac catheterization, right ventricular angiography defines the anatomic details of the right ventricular outflow. The pulmonary arterial pressure is lower than normal, 8 to 20 mm of Hg. Now, let's discuss what can be the management of patient with Tetralogy of Fallot. Medical management in TOF patients is directed towards preventing cyanotic spells, avoiding problems associated with anemia or polycythemia, preventing complications such as infective endocarditis. The general measures include correction of anemia by iron supplementation and nutritional supervision. The child is started on oral propranolol, 1 to 4 mg per kg per day in 3 or 4 divided doses to prevent cyanotic spells until surgical correction is done. A cyanotic spell is usually self-limiting and lasts less than 15 to 30 minutes. But sometimes they can be prolonged and require emergency measures like: hold the child in knee-chest position. This increases the systematic vascular resistance and decreases the desaturated systemic venous return. Calm the child. The ideal sedative is morphine. It causes respiratory center suppression and sedation, thereby reducing hyperpnea. It reduces the ventilatory drive and decreases systemic venous return. This will decrease the release of catecholamines, increase the period of right ventricular filling by decreasing the heart rate, and relax the infundibulum. The dose of morphine is 0.1 mg per kilogram, and it can be given intravenous, 4, intramuscular, IM, or subcutaneous. It may be repeated after 5 minutes. The ventilation facilities should be at hand. The other alternative sedatives are midazolam 0.05 to 0.1 mg per kg IV or dexmedetomidine 0.5 to 1 microgram per kg IV or infusion of 0.2 microgram per kg per hour or fentanyl 1 to 2 mcg per kg IV. Sodium bicarbonate in a dose of 1 to 2 ml equivalent per kg IV is given slowly to correct metabolic acidosis. This may reduce the respiratory center stimulating effect of acidosis and may diminish the increase in pulmonary vascular resistance caused by hypoxia and acidosis. It can be repeated in 10 to 15 minutes. 5 beta blockers like injection propranolol is given in a dose of 0.1 to 0.2 mg per kg for over 5 minutes and can be repeated once after 15 minutes. It decreases the heart rate, infundibular spasm, and increases systemic vascular resistance. Metoprolol can also be given in a dose of 0.1 mg per kg over 5 minutes. Another short-acting beta blocker which can be given is injection esmolol in a dose is 0.5 mg, 500 micrograms per kg over 1 minute and then as an infusion of 50 to 200 micrograms per kg per min up to 48 hours. If the spell is persistent or refractory, then intubation and mechanical ventilation may be required. Oxygen supplementation should be started. This causes pulmonary vasodilation and hence decreases the pulmonary vascular resistance. In surgical management, palliative surgeries can be done. Blalock Taussig shunt can be implanted. The Blalock-Taussig shunt, commonly called the Blalock-Taussig shunt, is a palliative surgical procedure used to increase pulmonary blood flow for palliation in cyanotic heart defects like pulmonary atresia, which are common causes of blue baby syndrome. In modern surgery, this procedure is temporarily used to direct blood flow to the lungs and relieve cyanosis until corrective or definitive surgery is performed. The pulmonary blood flow will be maintained preoperatively by maintaining ductal patency with prostaglandin E1, PGE1, and the definitive operations are performed later. Next is modified Blalock-Taussig shunt, MBT shunt. It consists of interposition of a polytetrafluoroethylene, Gore-Tex, tube graft between the subclavian artery and the right or left pulmonary artery. It is usually a non-bypass procedure and is performed through a lateral thoracotomy. Others are Waterson shunt. It is creating a communication between the right pulmonary artery and the ascending aorta. Potts procedure, creating a communication between the left pulmonary artery and the descending aorta. Tetralogy of Fallot can be corrected by closing the ventricular septal defect by resecting the pulmonary stenosis and often by inserting a right ventricular outflow tract patch. Surgical closure of VSD is done through median sternotomy using conventional hypothermic cardiopulmonary bypass. To achieve immediate complete closure, Dacron polyester patches, 6 to 24 mm, are sewn securely with polyester thread. Hybrid approach is also used to close the ventricular septal defect. Complications of TOF includes arrhythmias, which are common with Tetralogy of Fallot. Post-operatively infective endocarditis is common due catheter and surgery-based cardiac interventions. If left untreated, Tetralogy of Fallot rapidly results in progressive right ventricular hypertrophy due to the increased resistance caused by narrowing of the pulmonary trunk. This progresses to heart failure, which begins in the right ventricle and often leads to left heart failure and dilated cardiomyopathy. Thank you for listening. Like, share and subscribe.